Good evening, and welcome to Clinical and Business Strategies for Practice Growth during the COVID-19 pandemic. I'm Dr. Robert Lowe. I thank you all for being with us tonight, and hopefully can give you a little bit of information to take back to your offices on dealing with this this change that we've all had in the way we go about life, let alone our practice life. Some of the topics that we'll be speaking about tonight: growing your practice during the COVID-19 pandemic, single visit dentistry, is this the new normal? Early diagnosis and detection of Pitt and Fisher caries, updating a standard of care. Case selection for comfortable cavity preparation. Micro-invasive restorative dentistry and bioactive restorative materials. I'd like to put out a big thank you to the sponsor of this program, PulpDent Corporation, who I've had the pleasure of working with for several years. We'll be talking about some of their bioactive restorative materials as part of the answer to this clinical question: where do I go from here? As I've always told people in all of my lectures, we want you to leave thinking like a doctor. We now have many different excellent materials available to us. And in this time that we're facing a change in the way we practice, it's time, I think, to put yourself out as doing something different, something to best help your patients and your practice. And I think you will enjoy this next hour. In light of the recent pandemic, we'll all be looking for ways to help differentiate our practices as we move into this new era of dentistry. Aside from changing our offices and instituting even more rigid guidelines as far as infection control, expanding your practice using techniques and materials discussed in this webinar will give you a head start in getting all your practices moving smoothly again.
If you listen to Gordon Christensen, Dr. Christensen will say that, the main areas in growth, the main growth areas in general practices over the next several years will be in endodontics and ortho, in implants. And these are areas that are going to require time, expense, additional training, and again, keep in mind with these specialty areas that we will be judged at the level of the specialist as far as the quality of the procedure we're doing. So let's take a look at implants for a second. I mean, if you want to learn to place implants, you may need to take several courses. There are mini residencies and things like that, and these are not inexpensive. And then to be able to invest in the armamentarium that's required for placement, to stock implants and grafting material and other things that are needed to do the procedure. There's a lot of initial upfront expense just to be able to place that first implant. For endo, if you want to learn to do rotary endo, see, I went to school where rotary endo was not done. We didn't have nickel titanium instruments that could bend around a corner. All of our root canals were taught to be done with hand instrumentation. So there are, endo courses that can be taken to learn to do rotary endo, again, in single canals if you don't feel comfortable with treating molars. But there will be, again, an initial investment in time, and you probably want to do a few on plastic blocks and get proficient at the system before you go to the first patient. And then again, it's inventory. It's inventory of whatever you need to do root canals. When you look at ortho, you look at Invisalign. Invisalign is big with GPs now. It still takes a commitment for time and training and additional costs for armamentarium to start up. So while offering, I think, these adjunct procedures are good, you have to understand that there is a cost attached to that. When we look at restorative, and we look at how we can expand what we offer in restorative dentistry, all of a sudden the cost factor and the training factor really isn't so much of a thing to consider. One area I've found in my practice that really is helping grow the practice internally, which I think still is the best way to grow the practice, is through the use of comfort cavity preparation and minimally invasive technologies, early diagnosis, minimal preparation, and use of bioactive materials to help heal and maintain dentition for the lifetime of the patient.
Interesting little thing there, but quoting some of those statistics from Dr. Christensen, I mean, many people, even before the pandemic, were looking at expanding what they do in the general practice to help keep the patients in the practice and the revenue in the practice. And there are costs attached to that.
You listen to
So when we look at diagnosis, I think looking at diagnosis is really a key factor. We're now having more time to spend with our patients because we have to go through the cleaning and turning over of the room, and we're not able to see as many patients at a time, at a single visit, things like that. Take the time to do proper diagnosis and let the patient know what they need. Is there a concern over hidden caries? Well, I think there should be. I think we're well overdue. And if any time, like the present with this epidemic or a pandemic that we're dealing with, early diagnosis and treatment of our patients, I don't think could be any more of a forefront than it can be now. Studies on diagnostic caries indicates X-rays and explorers are rated poor as diagnostic tools and occlusal surfaces. We know that. The Explorer is a blunt probe. I mean, a fissure can be as tight as 10 microns, and bacteria are 1 micron in diameter. So imagine that Explorer that's been autoclaved thousands of times. It's not an Explorer, it's a blunt probe. And we know from caries, cariology in dental school, that pit and fissure caries, that's the tip of the iceberg. And that caries spreads in a triangle shape toward the cemento enamel or toward the dental enamel junction, and then laterally undermining cusps. Visual methods and caries risk assessment should remain a standard of clinical diagnosis in occlusal caries. 92% of teeth with subsurface stains or white decalcification have decay present. So, is this a stain? Are we going to watch it? We like to watch things get bigger until we justify putting cold steel and cutting a dog bone cavity extension for prevention cavity preparation. But is that really in the best interest of the patient? I mean, in today's world, I ask the patients 2 questions, and I've done this for a long time. You want to save your money or save your teeth? Because dental insurance is not going to pay to keep a dentition maintained throughout their lifetime. It's just not. It helps people who don't need dental work. We know this. The second question is, do you want to keep your teeth for the rest of your life? People are living well into their 90s. We have to be more proactive, I think, as a profession in helping patients maintain. And that means early diagnosis, early treatment, so that the average posterior tooth doesn't go through the filling, bigger filling, crown, endo and a crown, extraction, an implant, and then edentulous space. So is that a stain or is it caries? You know, if the blunt probe doesn't stick, you don't see anything on X-ray. But yet this was an extracted tooth from an ortho case and sectioned in half, and you can see, well, that while no caries was clinically detected, there certainly was an advanced carious lesion that was present. Now, if we watch this for 6 months, a year, 2 years, 3 years, how much of those cusps get undermined that when we finally do have a breakthrough on the occlusal surface that we can detect with our Explorer, now we're doing a much larger restoration than we could have done had we detected it much earlier. So technologies are changing the way we treat and the philosophy of watch and wait. And I think now during this time of the pandemic, we owe it to ourselves and our patients to look at some of these technologies to do a thorough diagnosis and treat conservatively. See, to me, it's more conservative to treat early than it is to watch things get bigger. In my practice for several years, I've been using intraoral cameras, and this particular intraoral camera from Acteon, the SoPro Care or SoPro Life. These cameras help detect early carious lesions that an explorer can't detect through a science called selective laser fluorescence. And laser fluorescence has been shown to be effective in the detection of carious lesions on many fronts, but yet I lecture quite frequently, and people aren't even familiar with or use Diagnodent, which is another tool to detect early decalcification. So the science is there. The average doctor does approximately 1,100 cavity preps a year. You know, and when talking about comfortable cavity preparation and using a fissurotomy burr, early detection means that there is a potential that these lesions can be treated without the use of anesthesia sometimes, depending upon the particular tooth in the patient. And we'll talk a little bit about that. But there definitely is a value there in chair time and savings. And the thing is now, when you've got your patient there, do the diagnosis and do the treatment.
Let's talk a little bit about case selection for comfort cavity preparation. Just like any procedure, comfort cavity preparation requires that you choose the proper patient. So let's talk about.
Sorry, we're getting having a little problem with the audio here, but
the hygienist takes a little bit of air to dry off the teeth, and maybe there's a little bit of root exposure and some dentin hypersensitivity, and you can just see the patient's gripping the chair a little bit tighter and getting ready to jump when that blast of air is going to hit the teeth. This may not be a good patient, a good candidate for an anesthesia-free procedure. So we want to take a look at the parameters. Another parameter would be patient's age. We know as patients get older, or as I tell them, as their teeth get older, the pulp chambers recede and shrink, and the teeth become less sensitive. So a lot of times we can prepare teeth without anesthesia on older patients, and there's no problem anyway.
Sorry for that little glitch there.
Let's talk a little bit about case selection.
So fissurotomy, what is it? You can see on the description and the visuals up above, the class 1, using a fissurotomy burr is going to conserve the amount of tooth structure in making entry into a carious lesion. And if you go into dentin, that green burr is called Smart Burr 2. This also is part of the comfortable cavity preparation kit from SS White. This is a polymer burr made of a Knoop hardness of 90, which is the hardness of healthy dentin. So it will only remove carious dentin, infected dentin, and showing the same approach on a carious class 5 below. So gaining patient acceptance, early diagnosis and minimal cavity preparation, bioactive restorative materials equals keeping your teeth for a lifetime. And training your staff and your doctors and patients on this dialogue and chairside education with patients and things like that, patients respond favorably. They're all about saving their teeth. I haven't had one patient say they don't want to keep their teeth for the rest of their life. So this dialogue about early detection and minimal preparation and the use of bioactive restorative materials is a dialogue that I think patients are ready to hear. And particularly in this time of pandemic, where you may not be seeing patients as much on a regular basis. I mentioned single visit dentistry. I mean, this is something that can be done in minimally invasive preparations, where I've had cases, a patient will come in, we'll do their exam, we'll find, if we find a couple of lesions, we can sit down and get that done while the patient's in the chair. A lot of times this involves using an isolite or a dry shield, high vacuum suction to control the aerosol. Electric handpieces. Here I'm using BN Air handpieces because I can control the RPMs, and I can better control the aerosol. And in cases like this, where we can do multiple teeth at one time, it works for the doctor, it works for the patient. We can minimize the turnover in the rooms. It's just a real nice way, actually, to practice dentistry. So let's talk about the materials aspect now, and what is bioactivity, and what does that mean? We're not doing fillings anymore. Fillings are things that are inert, that cause no biologic activity or help the tooth at all. They occupy space. Bioactivity is a concept that was first introduced in the late 60s, and then later defined as follows. A bioactive material is one that elicits a specific biological response at the interface of the material, which results in the formation of a bond between tissues and material. This isn't something that happens with traditional composite. This isn't something that happens with metal or zirconium or anything like that. The current status of dental materials, conventional dental restoratives, are passive and provide no biologic effect. The breakdown of the dentin bonding agents over time is a major cause in the limited lifespan of direct and indirect restorative materials. Technique sensitivity can and does play a major role in the use of bonding agents. Light curing devices are a major variable when placing composite materials as far as depth of cure. Bioactive restoratives stimulate apatite formation. This is the new definition. This is what we're looking for in restorative materials. PulpDent Corporation has a material called Activa Bioactive, and they also have a base liner and a cement. Biodentin from Septidont, MTA people may be familiar with, Viscose, Theracal. These materials have been shown to stimulate apatite formation. FDA's 510(k) approval for Activa Bioactive allows for claims of a bioactive resin matrix with bioactive glass fillers and the release of favorable ions into the oral environment. This is where we're at with our restoratives now. Having ion availability so that demineralized tooth structure can become remineralized to healthy apatite. This study by Jeffries and his group a few years back shows apatite formation closing marginal gaps in dental cements. And what Jeffries and his group did was they took a test material, restorative material, placed an artificial gap of about 30 microns between a dentin substrate, and place cement. And you can see after so many days in a saline solution, self-adhesive resin cements, there's no difference in the gap. Resin modified ionomers, no difference. Glass ionomers, no difference. But when you see calcium aluminate and calcium silicate, these bioactive materials, you can see that these materials are stimulating apatite formation to close these gaps at 23 days, 30 days, 58 days. Calcium-based bioactive materials can stimulate apatite formation and close 50 micron gap interfaces. So when you think about it, and you've got a restorative material in your mouth, your patient's mouth, you want something that can provide this benefit. Do you think there's a long-term benefit to having a material that can effectively close margins over a period of time and replace demineralized appetite with healthy appetite, I think there is a tremendous, tremendous benefit from looking at and using these types of materials. Recent studies have shown that resin-based dental composites containing bioactive glass reduce biofilm penetration into the gaps. In other words, help prevent recurrent decay. This suggests composites containing bioactive glass may show the potential to slow the development of secondary tooth decay at restorative margins. Bioactive materials can have an inhibitory effect on caries due to the buffering effect of calcium and phosphate ions released into the microenvironment. This buffering effect is big because, there are patients that don't know which end of the toothbrush has their bristles. And, bacterial metabolism produces an acidic byproduct that demineralizes tooth structure. So buffering ions can help decrease the negative deleterious effects of these acids on tooth structure. Here's a slide that shows appetite formation on the surface of Activa Bioactive Restorative after 21 days in a saline solution, mimicking saliva, showing calcium phosphate appetite formation on the surface of the material. So why are bioactive products important to you and your patients? It's plain and simple. Delivering minerals that are beneficial to tooth structure, minerals that support conditions that stimulate mineralization and the formation of chemical bonds that help seal the tooth and prevent microleakage. Now, if you're not familiar with the names of Salvatore Saro, David Pashley, and others, these are some of the prominent adhesive researchers in the world. And they're all saying that this phenomenon, this effect of ion availability is what we need to help seal margins and create restorations that give patients the ability to keep their teeth for the rest of their life. This ionic activity is beneficial for tooth structure and surrounding tissues, obviously. So why are these products important to you and your patients? They can reduce sensitivity by buffering the acidic effects of bacterial metabolism. You also reduce dental hypersensitivity or the potential for dental hypersensitivity. Bioactive products can help reduce marginal leakage and marginal caries, in other words, affect the life of the restoration. And they can also be less technique sensitive. These materials are, for the most part, are much more moisture tolerant. The average composite resin is hydrophobic. These materials are water loving, hydrophilic. So there is less technique sensitivity in placement. So let's look at some of these cases and talk, talking to your patients about the value. Because again, getting back to the pandemic and the way we're taking more time with our patients, I don't necessarily think this is a bad thing. This is the time to educate your patients, to bring them up to speed with what's available to them. Independent research shows that 15 to 20% of the patients are needle phobes. Well, I don't know that I can say that that's the number in my practice, but I will tell you that patients don't like getting a shot. They don't like feeling numb after the procedure. That's more of a true statement. 6 to 10 minutes of time savings to wait for anesthesia and multiple quadrant procedures that can be achieved in a single visit. These are all values to early diagnosis and treatment with comfortable cavity preparation techniques. Clinicians have reported completing 500 cavity preparations with SmartBird 2 and no anesthesia, saving 83 hours of chair time per year. Well, that's nice with numbers and things like that, but I tell you, it's all comes down to that patient in the chair at that time and having a good experience. I always tell patients, look, there's a chance that we can do this procedure without numbing you up. I feel comfortable that we can do that. If at any time you're not comfortable, you let me know. We can always give you an injection. We can always numb it up. We can always take care of that. But now we have a choice. How about composite repairs? Dr. Ron Jackson, colleague and good friend, had always said that composites, unlike amalgams, can be renewable, not always needing replacement from minor marginal leakage. And if this can be detected at an early time through diagnostics, fissurotomy burrs are very useful in removing that little bit of decay or a recurrent decay that could be visible at a margin, those brown lines where people say, oh my gosh, there's micro leakage, it's failing, we got to replace it. Well, if you take a fissurotomy burr and you basically erase that little brown line and you're down to clean resin and clean tooth structure, the bonding procedure really has prevented that dreaded decay from getting in and surrounding the restoration, unlike it would prevent it with an amalgam. And these areas can be repaired. Renewing a composite restoration using a fissurotomy burr and then flowable resin. So again, conservative dentistry is, to me, early diagnosis, minimal cavity preparation, and renewing restorations where we can to prevent that next larger preparation from needing to be made. And conventional cavity preparation with a 330 or a pear-shaped burr, you can see the difference between just early opening into a carious pit versus with a fissurotomy burr. And looking at this chart, just a quick review shows that the volume of tooth structure removed with a 557 or a 330 versus the fissurotomy is quite a bit of difference, 80% less tooth structure removed with a fissurotomy burr when compared to a 330 at 2 millimeters. So here we show again entry. Enamel 360 to 440, that's the Knoop hardness of enamel. A carbide is 1600 as far as Knoop hardness. Infected dentin. Infected dentin is dentin that's been demineralized and is infected with bacteria, is 0 to 30. Healthy dentin, unaffected, 70 to 90. So learning the differences of dentin, infected, affected, is important, knowing that infected dentin needs to be removed. It's demineralized dentin that's full of bacteria. Affected dentin, there's no bacteria in that area yet, but it's starting to demineralize. These are the areas that still may stain with caries detection dye. With a real brand new Sharp Explorer, you still may get a little stick, but it's not removed with a SmartBurr 2, Knoop hardness a 90. That type of dentin, that type of affected dentin can be remineralized with bioactive restorative materials back to a state of health. So here's a couple clinical cases. What do you think? Watch it. Patient doesn't come in a regular recall visit. See, that's another thing, as I always say, be a doctor. If the patient comes in every 6 months and has one filling in their mouth, I may give them a pass on some of these small areas because we can monitor. But when you see breaking through like this, the concern over hidden caries and the fact that caries can travel once it gets to the dentino-enamel junction laterally and undermine cusps, I'm thinking more about micro-invasive restorative materials here than I am waiting for these lesions to get worse. Or like in school, cutting the big dog bone extension for prevention cavity preparation that Dr. Black espoused back in his work, Operative Dentistry. You can see the restored tooth at the bottom right. Doesn't look like it's been invaded at all. To me, that's conservative dentistry. And with a bioactive restorative material that has ion availability for marginal sealing and the other things that help promote healthy tooth structure, I expect those restorations to carry on for quite a while.
When I'm doing any excavation, based on clinical information and an X-ray, I'll do my minimal access form with a fissurotomy burr, just so I can gain access with the smallest smart burr and start excavating any type of lesion that extends into dentin. If I need to open up the prep a little bit more to gain further access because I'm chasing the decay buccally or lingually or whatever, I do that. But my goal is to maintain as much of the healthy tooth structure as possible. And then get the smart burrs in, remove the infected dentin, and then use bioactive liners and restorative materials to effectively seal the tooth. So that, in a nutshell, describes the procedure. When I'm doing any excavation.
Sorry about that. So you see, we got a few different sizes of fissurotomy burr. I tend toward the micro NTF or the micro STF, but all of the, including the original, allow for minimal access to the carious lesion. So again, we already said that bioactivity was first introduced in the 60s by Kao and Hench, eliciting a specific response. But Hench expanded on this concept in 1996. Bioactive materials create an environment compatible with osteogenesis. And this mineralization process forms a natural bond between the living tissue and the non-living synthetic restorative materials.
As you know, there is a continuous release and uptake of ions from the teeth in the oral environment, reacting to changes in pH, changes in diet. We lose calcium and phosphate when the pH is low, and when the pH is higher or there is an availability of calcium and phosphate, these ions can be reincorporated into the tooth structure. We now have a new class of restorative materials that are bioactive, truly bioactive. For many years, we felt that fluoride release, this made something bioactive. And while fluoride is good to convert hydroxyapatite to fluorapatite, which increases the resistance of tooth enamel to the acid attack from bacterial byproducts, it is not able to replace the calcium and phosphate that are needed as rebuilding blocks for demineralized tooth structure. Traditional materials are unable to help support this rebuilding process. To review, dentin is really made up of 3 different components. We have healthy dentin. We have, in the cases of demineralization and bacterial assault, we have infected dentin. Now, infected dentin has lost calcium and phosphate and also is inundated with bacteria and bacterial byproducts. This is traditionally the decay that we scoop out of a preparation with a spoon excavator or a slow speed round burr. This is infected dentin. Affected dentin, on the other hand, is at the periphery. Bacteria has not yet invaded this area, but the effect of the lower pH has already caused the leaching out of calcium and phosphate from this, hence calling this affected dentin. Now, bioactive materials that have calcium and phosphate availability can provide the building blocks to help the natural process of remineralization and turn this affected dentin back to healthy dentin. That's the big difference. Bioactive materials are dynamic, and they do participate in this ion exchange and support natural remineralization through this process.
So to re-emphasize, early diagnosis, I think, is key. The use of quantitative laser fluorescence now enables us to detect caries at an early stage. And discussing this with patients, and this is what I tell them. I say, you see that the red line in there, that means that there's active caries present. We can do one of two things. We can watch it get bigger, or we can treat it. But I will tell you one thing, that carious lesion, that area of decay, is not ever going to be as small as it is today. It can only get bigger. So what do you want to do?
Part of my diagnosis starts with using SoProCare. This is an intraoral camera by Acteon, which has a function that looks for decay. In other words, this particular camera with this caries function can help find decay when an explorer cannot. And this is through the science of quantitative laser fluorescence. So that when you look at the patient's tooth, and I explain this to the patient, you see the dark red in this fissure? That is active bacteria producing metabolic byproducts. Those metabolic byproducts are acidic, and they're causing the demineralization of the tooth. In other words, a cavity. You see the pink area around? The pink area is affected. There's no infiltration of bacteria yet, but calcium and phosphate are leaching out of that healthy enamel and causing the spread of this decay both buccolingually and pulpally. Now, this may or may not stick with the explorer, and I tell the patient, there's no such thing as a small cavity. And also, it's never going to be smaller than it is today. So my whole goal is to educate on the importance of early diagnosis and minimal invasive treatment. And this can be done with the proper equipment and with the bioactive restorative material. Using fissurotomy burrs from SS White, I make a very minimalistic approach into that fissure and start to remove the dark red line. And as I go pulpally, I'll stop, take another picture. Here you can see there's still some active decay in this area. And in this area, this I don't worry about so much because Activa will help remineralize that to healthy enamel and dentin. So as I make the preparation, I check with quantitative laser fluorescence to make sure that the infected area of enamel or dentin is removed. Here you can see that there still is a little bit remaining on that vertical wall, the buccal wall of the cavity. And we'll go back and instrument that a little bit more. And then after instrumentation, again, using a fissurotomy burr from SS White, early diagnosis with quantitative laser fluorescence using SoProCare, we've maximized tooth, maximized saving as much healthy tooth as possible without extension for prevention or removing affected dentin, which can be reversed into healthy dentin by a bioactive restorative material like Activa. After restoration with Activa Restorative, the tooth is made whole again. The restoration is invisible.
There's a little bit of water spray there.
We didn't get it totally dried off, but I expect that restoration to be long-lasting and help remineralize any affected tooth structure that's underneath, and at the same time protect from microleakage and recurrent decay, since materials that have calcium and phosphate also help seal margin gaps. So as restorations age, if gaps are to form, we have a source of calcium and phosphate to maintain and fill those gaps, which we don't have with conventional restorative materials.
So again, early diagnosis, comfortable cavity preparation using fissurotomy burr, and then bioactive restorative material. We discussed Activa Bioactive from PulpDent, but this is a new kit on the block, Activa Presto, which is a light cured universal stackable composite, ideal again for these types of restorations. This particular quadrant was done in one visit and then restored with Activa Presto. After checking occlusion, adjustment with composite finishing burrs that are also included in the comfortable cavity preparation kit. And then polishing with ASAP polishers from Clinician's Choice. Those nice little rubber fingers get down into the grooves and do an excellent job in polishing. You can see preparation and restoration in the same slide. You wouldn't know that those teeth were assaulted with a burr, but they've got the decay has been removed, the bacteria has been removed, and a bioactive restorative material with calcium availability is there to help in marginal protection and remineralization as needed. Removing decay with the fissurotomy burr followed by the smart burr allows you to remove infected tooth structure without inadvertent pulp exposures. If you're using a carbide round burr, this is not possible because the carbide steel cannot detect the difference between infected and affected dentin. University of Maryland study concluded the use of SmartBurr 2 is an efficient method of removing caries, infected dentin, while preserving caries, unaffected dentin, and conserving healthy tooth structure. And this plays right into the role of bioactive restorative materials.
Now let's talk about use of SmartBurr 2 in excavation of dentin, because this is something important to understand. The SmartBurr 2, this little green round burr, and there's different sizes that correspond to conventional sizes of round burrs. This is a polymer burr. This is made of a specific hardness so that the flutes will not cut healthy dentin. Now let's talk about use of SmartBurr.
So here's a clinical case of mine where, hidden caries. We've broken through with the fissurotomy burr. We can see, particularly on tooth number 19, decay has advanced beyond the dentin-enamel junction. This actually was diagnosed with, as I had mentioned before, Cavo's Diagnodent. And then caries excavation is completed with SmartBurr 2. And then etch and bond and restore with Activa Presto. How to increase the durability of dentin bonds? This is something to remember from Pashley and Tay a few years ago, and the release of MMPs or matrix metalloproteases that happen when we etch dentin. This particular product, Hemoseal Inside Desensitizer, has chlorhexidine in its makeup. And when applying a desensitizer, the role of desensitizer is to plug the tubules, yes, but the chlorhexidine is going to help inhibit the release of MMPs from collagen, thereby increasing the durability of the dentin resin bonds over time. So just another thing to consider when you are using an etch and rinse technique, that a desensitizer such as Hemoseal Inside with chlorhexidine is going to give some added protection as far as preventing the breakdown of the dentin resin bond. So speaking of that, one question with bioactive agents is how can they work through these bonds? Do we use etch and bond on all restorations? I think, to me, that's do I need additional retention? If I've got good retention, I don't always etch and bond, although there's no reason that you can't, because ions released from Activa do pass through the bonding agent. There's evidence that this happens. Activa helps prevent the breakdown of the bonding layer. In other words, the release of MMPs helps inhibit that. And the bonding agent is applied using a two-step etch and rinse technique and using a desensitizer, as I had mentioned. Degradation of the dentin bond is a leading cause of composite restorative failure. This is cited in the literature in many different places. And studies indicate that lower concentration of MMPs exist when Activa is used as a restorative material. So you see how these things all start to work together and make sense. Here's again an SEM showing the surface of Activa with calcium and phosphate apatite formation on the surface after 21 days of exposure to moisture. And again, another study that was done at Tufts showing that fluoride release of bioactive restorative agents or bioactive restoratives with bonding agents, that these the study concluded that fluoride ions do pass from the restorative material and are able to penetrate through the adhesive bonding agents. So in other words, the adhesive is like a semi-permeable membrane, and these ions are small enough to be able to penetrate through and precipitate on the opposite side. So there is no reason not to use a bonding agent, and in fact, you don't have to worry that if you do, that you lose some of the effects of the precipitation and the release of ions. Here's a study done by Soro and Pashley, again, to highlight that point that Activa and bonding agent, you get no bonding degradation, and with traditional composites and the release of MMPs, there always is that possibility of degrading the bond over time. So I mentioned Activa Presto. I want to expound on that, and at the time we have left a little bit because the early diagnosis and preparation is just 2/3 of the game. Using materials like Activa Restorative, Bioactive Restorative, and Activa Presto now. Activa Bioactive Restorative is a dual cure material. It can be used in bulk fill. Activa Presto is a universal stackable composite. It's a light cure, first light cure composite designed to mimic the properties of natural teeth. It has stackable and shape. It's stackable and shapeable, has a low flow, light cure composite. It holds its shape and doesn't slump. Presto is a versatile, aesthetic composite that is easy to place, highly radiopaque, and indicated for all classes of cavities. Finally, we have a truly universal composite material that also mimics natural tooth structure and has ion availability. It's dynamic, moisture friendly, dentin and enamel replacement material that releases or recharges calcium, phosphate, and fluoride. Presto is formulated with the patented rubberized resin, rubberized urethane that is strong, durable, and wear resistant, fracture resistant, even in areas of thin margins and bevels. So physical characteristics of this material is excellent, plus the fact that it's moisture friendly and has ion availability makes it unique in the composite world. The resin is urethane based, contains no bis-GMA, no bisphenol A, no BPA derivatives, and comes in a variety of shades. In fact, I worked with PulpDent on the cervical shades. So if you have an older class of patients in your practice that have carious lesions on the root surfaces, you're going to find that this material is ideal for not only restoring, but aesthetically, it can't be beat. The thing that's unique about Activa Presto, it has a modified calcium phosphate. This contains a patented modified calcium phosphate that's soluble in monomers and is attracted to the calcium in tooth structure. The material penetrates and integrates with the tooth, providing a margin-free adaptation and an excellent seal. This hydrophilic resin facilitates the diffusion of essential ions, and the modified calcium phosphate creates nucleation sites for apatite formation. In other words, helping to seal margins and maintain margin integrity. These are two fundamental elements in Presto that mimic nature. They don't exist in other products. PulpDent's early product Embrace technology really paved the way. The first ionic resin available on the market, and then rubberized materials in Tough Temp Plus paved the way for use of rubberized urethane and shock absorbing technologies. These are used in the formation or the development of Activa Presto. Physical properties, you can read this quickly. Depth of cure, 2.5 millimeters, percentage of weight by fill, 70%. All of these are compatible with the best physicals that you see and other composites on the market. As I said, those other composites on the market just fill the holes. They don't provide the biologic effect and the bioactive effect that this material does. The tooth is the standard. Activa is aesthetic, it's moisture friendly, has high strength, releases calcium and phosphate, and is shock absorbing. We can't say that about any other composite on the market. Activa Presto truly mimics tooth structure in each of these categories. And placement is just like you would place a standard composite. Preparation, bevel where necessary, total or selective etch, apply your bonding agent, place in 2 millimeter increments, light cure, finish and polish. Here's a case of mine that I published using Activa Presto A6 in the class 5 areas, creeping around into the proximals on these teeth, older patient. Show beautiful aesthetics and protection with bioactive resin. Here's a class 2 courtesy of Dr. Robert Ho, showing a class 2 filling replacement with Activa Presto A3. And one from Dr. Danielle, really a severe caries case where Activa Presto was used to do a beautiful restorative procedure on this patient. And Dr. Ray Kinsey, showing a class 3 mesial on the cuspid. So you can see a variety of cases where Presto is used in an everyday restorative case to not only give a beautiful aesthetic result, but to create a bioactive material, create bioactive protection by release of calcium and phosphate and helping to protect the integrity of the margins over time. So we get that a little bit too. I do want to make a point because I've mentioned bioactive materials here. Activa Bioactive Restorative and Activa Presto. There is a little bit of similarity between the two materials, and there is some differences. As I said, Activa Bioactive is dual cure. It contains some glass ionomer. It's injectable. It's ideal for bulk fill, not as many shades. A great restorative material in the pediatric area because of ease of placement and less technique sensitivity. Activa Presto, on the other hand, is light cured. It contains a modified calcium and phosphate. It's a one-step place and contour, 2.5 millimeter increments in all classes with a wide variety of shades for aesthetics. But both of these materials, I think you will find, provide good natural aesthetics and are less technique sensitive and protect teeth for the long term from calcium phosphate enrichment and the availability of these ions over the life of the restoration to provide a durable seal at the margin and help protect tooth structure. Here's a case of mine that I just recently did showing an update on the sandwich technique. I actually used Activa Bioactive Restorative as the dentin replacement on this area, tooth number 3, where we had a failing restoration. Patient really couldn't afford anything at this time other than a direct replacement. So you can see the minimal amount of visual caries, but you can see what happens when you early diagnosis with quantitative laser fluorescence. You find what's really happening underneath. I used Etch and Rents and Activa Bioactive Restorative as the dentin replacement, and then Activa Presto for the enamel layer. And you can see the nice polished result on the right screen. So the magic is in the resin. Moisture-friendly, mineral-enriched ionic resin facilitates the diffusion of calcium phosphate and fluoride and integrates with tooth structure. Patented rubberized resin is tough, absorbs shock, and resists fracture, wear, and chipping. Patented modified calcium phosphate component is soluble in monomers and binds to the calcium in teeth. Urethane-based resin contains no bis-GMA, no bisphenol A, or no BPA derivatives. So it is truly magic. It is the thing that completes the circle. Early detection, minimal preparation, and long-term protection of healthy tooth structure.
Let's summarize the information that we've shared with you today. But what we've discussed is different ways to add on value to your existing practice, whether it be through continuing education, providing other services and other techniques such as implants and endo and ortho, and reminding you that there's something you're doing already that you can implement tomorrow, and that's restorative. There's cavity preparation, comfort cavity preparation, different approaches to what you're already doing that take minimal time and investment to implement and can help you grow and increase not only your patient satisfaction, but your practice volume as well.
I will tell you that since I've been implementing these procedures in my practice, both before the pandemic and during, I'm doing more composites, I'm diagnosing more, I'm doing more direct restorative dentistry. Patients are understanding the need for early and the benefit for early detection and placement of bioactive materials. And I'm charging more for this. There's a benefit to the patient, and they should, and they will, and they do understand that. It isn't just, oh, well, my insurance covers this. They say, well, your insurance covers for a traditional filling, and your traditional filling might wear out faster or not seal as good or whatever. We have these new materials, and patients understand the benefits when you explain it to them. So it's a win for everybody. In this situation we're faced now, where we're all, the buzzword is going to be pivot your practice and do all this stuff to help maximize. I think the best thing you can do is get better at what you're doing already. Yeah, it's great to go take implant courses and do all this other stuff, but most general dentists are doing restorative dentistry every day, and to implement early diagnosis, minimal cavity preparation, and bioactive restorative materials not only benefits your practice, but benefits your patients.
I hope this little lesson on bioactivity and restorative materials has been of help. I think from the description and the pictures, this particular segment can be used to educate not only patients, but doctors as well, as to what bioactive restorative materials can do for you, your practice, and your patients. If there are any questions, you could always reach me at boblowdds@aol.com. I appreciate you listening to this short little informative webcast, and look forward to talking to you again in the future.
So it looks like our timing is good. We still have a few minutes. We'll take some questions. I can go over here and hit the Q&A button, and let's come up here. So I did, Victoria, I did not understand. Smart burrs are made of what? Well, it's made of a plastic polymer. It's proprietary, I don't know exactly, but it's a plastic polymer, and the new hardness of them is 90, which is the new hardness of healthy dentin. Smart burrs, they call them that because they take away the bad and leave the good. Because they look like plastic to me. They are plastic. Can we use Activa Presto for the labial surfaces of anterior teeth? Absolutely, you can use Activa for Presto for the labial surfaces of anterior teeth. Beautifully aesthetic material. Polymerization shrinkage of 2 seems a bit higher than others. Any problem? Not sure, Peter, what you're referring to. Polymerization shrinkage of 2 seems a bit higher. Although I tell you, in general, polymerization shrinkage, anything less than 3% by volume is really, the question is whether there's a actual clinical concern or not, and that can be argued among scientists. But as a clinician, I'm not seeing any problem with the shrinkage of any of these materials. Thank you so much for your comment. Doesn't its color go darker with passing years? Maureen, I'm not sure exactly what you're referring to, but teeth do darken over passing years, and that's true, and restorative materials do not. So sometimes if there's aesthetic problems with older restorations, they may be replaced for aesthetics only, not because of marginal integrity or leakage. What adhesive works well with bioactives? Good question. I think the majority of them work well with bioactives. I'm not a scientist. Again, take a look at Dr. Soro's work, S-A-U-R-O, Salvatore Soro. He would probably have some information on that. And there may be a few different adhesives that don't work as well, but I'm not that familiar. I know that what I generally say as a clinician is I say use the adhesives that were made and formulated to work with the composites. So when dealing with PulpDent's restorative materials, PulpDent has a fine adhesive called Uno that works very well. It's made to work with these materials. If you're using somebody else's materials, use their adhesives. I try not to mix families as far as restorative and adhesive systems. How do you feel about extensive caries restoration using Activa and other bioactive materials without resorting to, for example, crowns? I think I can go into a whole area of heroic dentistry as far as that goes, but I think that patients can't always afford a crown. So extensive caries restoration using Activa and bioactive materials help people keep their teeth. Can you use a different code for the bioactive restorative material? I'm not sure that you can. I think you're referring to insurance codes. Insurance companies, insurance in general lags far behind. I've worked with lasers for 3 decades, and it took a while to get a code for lasers. Right now I'm still coding as a composite, but you could always try the 9999 and put your narrative in there. But right now I'm just using traditional codes. Is it a microfill as far as polishability is concerned? I assume you're talking about Activa Presto, and yes, it's a micro hybrid, not microfill. Where can we get smart burrs? I'm from India. Smart burrs are made, are distributed, or manufactured by SS White. So I would imagine that your local distributor would carry SS White, or they may have their own distribution there. A good source in India for any of this information would be Dr. Rumpa Wig, W-I-G. You can probably get a hold of her locally. Can you use Activa Presto as a flowable, uncured, in an interproximal box, bulk fill composite injected? I personally don't like to use flowables uncured in an interproximal box in the deep class. I cure everything because you don't know that the light's not going to get down there. So I would use Activa Presto in a deep proximal box, but I would, actually that's the good place to use Activa Bioactive Restorative, because you do have dual cure, so you don't have to worry about whether it's going to be cured or not. Anyways, I think that looks like the end of our questions. I hope you enjoyed the material that was presented, and again, it's a pleasure. And thank you for spending this time with me. And if you have any questions, I'd be happy to answer them. If you would send me an email to boblowdds@aol.com. I want to thank Viva Learning for hosting this webinar, and again, PulpDent Corporation for their support for both education and the advancement of dentistry. So with this, I will say thank you very much and have a good evening.